So good morning. One more. This is the last in service on stroke, and it is going to be, and we're going to hear it from Cesar, and it's the last in service for the month of June 2020. So Cesar, it is all you.
Okay. Okay, so as Dr. Baldwin mentioned, my name is Cesar Asensio. I'm the last fourth year student and the last of the fourth year students presenting today. And today I will talk to you guys about stroke. Okay, so what I hope you all get from this presentation. So at the conclusion of this presentation, the participant will be able to describe what a stroke is, the risk factors associated with it, list the three main types of strokes, and what I would probably consider the most important is recall the BFAST acronym for stroke. So this is sort of the way this presentation is going to flow. So I'll first start off with the definition of a stroke and move on to why it's important. And third, we'll move on to the treatment. And with the treatment, I'm going to focus more on ischemic and TIA, or transient ischemic attack. Those are the two of the three most common types of stroke. And lastly, I'll move on to post-stroke, or what interventions are done after a stroke. So what is a stroke? So stroke is when the arteries that carry blood, oxygen, and nutrients to the brain is blocked. And that can be either by a clot or a rupture in the blood vessel. Ultimately, this deprives the brain cells from oxygen and nutrients, and those brain cells start to die. So I'm going to move into just a basic anatomy of the brain. So the brain is a complex organ that functions as our command center of the nervous system. And it controls our thoughts, our motor skills, our breathing, our vision, our memory. And depending on the type of stroke that someone experiences, they'll have different impairments. So here, as you can see on the figure on the right, these are the five main lobes or parts of the brain. So our frontal lobe here is the part in red, and that controls our it's responsible for our motor control. So our concentration, our planning, our problem solving, speech and smell. And our parietal lobe is here in yellow, and that's for our sensations, so touch, pressure, and taste. And our temporal lobe here in green, that's for our hearing and facial recognition. And our occipital lobe is back here. And as the name suggests, that's for like our vision. And cerebellum is here in blue, here close to the base of the brain, and that's our coordination and balance. So depending on where the stroke occurs, those are the deficits that the patients will experience post-stroke. So why is stroke education important? So it's important. These are some statistics that I found in CDC. So it's the 5th leading cause of death in the US. And about every 40 seconds, someone in the US has a stroke. And stroke reduces mobility in approximately half of stroke survivors 65 years or older. And here to the right, there's a graph here that shows that there's a disproportionate amount of strokes that occur. The part where it's more purple than the rest, that's where there's more stroke incidences. And as you can see, it's more concentrated towards the south. And if we think, with down here in the south, there's There's a diet comes into play. So there's with the Southern diet, there's a lot of fast food consumption. There's higher rates of high blood pressure. There's higher rates of diabetes. There's higher rates of high cholesterol. So all of these components come into play. And I'll get more into the risk factors a little bit later on, but those are risk factors for strokes. So this is probably the most important part of the presentation. So warning sign of a stroke. So it's important to be familiar with this acronym, which is essentially a acronym to recognize signs and symptoms of a stroke. And this can help a patient get treatment in a timely manner. As I'll explain later in the presentation, it's important that patients who experience a stroke get treatment as early as possible. So B stands for balance. So if someone is experiencing trouble walking, is stumbling, falling, or feels dizzy. E is for eyes, so they have blurry vision, double vision, vision loss. F is for face. This is probably the one that most are familiar with. So face is drooping on one side. Arm, so there's arm weakness or numbness. Speech, so slurred speech, difficulty speaking. And T stands for time. So this means that if anyone's experiencing any of these symptoms that I mentioned, that's needs to be a quick call to 911 so the patient can get treatment as soon as possible. Okay, so moving on to the types of strokes. So there's ischemic stroke, which is the most common. It's about 85% of most stroke cases. And there's transient ischemic attack, and that's sort of a mini stroke. And the hemorrhagic, this one's less common, but it has a higher mortality. When I get into the treatments, I'm going to focus more, as I mentioned, as I alluded to before, I'm going to focus more on the ischemic and transient ischemic attack. And I believe on the next slide, I'll explain the pathophysiology of what's going on. Okay, so this is what's going on in the types of strokes for ischemic here. So there's an obstruction within a blood vessel supplying the blood to the brain. And this can be due either to a clot or to atherosclerosis, which is atherosclerosis is essentially when a fatty substance called a plaque, that's a medical term for it, a plaque accumulates inside the wall of a blood vessel. And what that does is that the accumulation, it narrows the blood vessel. So as the blood vessel narrows, there's less blood flowing through that blood vessel, and the brain is getting less blood, so it's getting less oxygen. So hemorrhagic stroke is when there's a weakened blood vessel that ruptures. So an example of that is here, if you can see like this balloon type of structure here. So that's a aneurysm. So aneurysm is an abnormal, it's sort of like an abnormal bulge or a ballooning of the blood vessel, and that can rupture, and that can cause what we call internal cranial bleeding. And transient ischemic attack. So this is it's similar to ischemic, however, it's a temporary clot. It's only temporary. So there's usually with transient ischemic, there's no damage to the brain cells, since it resolves within minutes, and the stroke symptoms are resolved within an hour. All right, so moving on into the screening. So with screening, there's various types of ways that a patient can be screened for a stroke. So there's a CT scan, MRI, and a physical exam. So with the difference between a CT scan and an MRI. So just to put it in simple terms, so a CT scan is usually uses X-rays to make a detailed vision of the brain, and our MRI uses magnetic. Yeah, so it's more of a magnetic component to it to make a detailed vision of the heart. And most hospitals have it. A CT scan is more available. It's less expensive. So most hospitals have a CT scan compared to an MRI. And the CT scan, however, it won't catch if there's ischemia going on. So ischemia is that meaning that there's not blood flowing to the blood vessel, and you'd be able to see damage to the brain here. It's not going to catch that as quick as an MRI. So MRI can see the abnormalities of a stroke within 30 minutes. A CT scan, however, would take a little longer time. However, the CT scan is more sensitive for hemorrhagic stroke. And physical exam, so the neurologist or radiologist will assess a patient by those symptoms that I mentioned, so the face drooping. And they also, what is used is there's a scale called the NIHSS, so the National Institute of Health Stroke Screening. So the scale is just a series of questions that assesses the patient's vision, balance, coordination, and they're assigned points. So the higher amount of points they have, then the more severe their stroke is. Okay, so moving on to the stroke risk factors. So some of the risk factors here are unhealthy diet. There's physical inactivity, smoking, and smoking is probably one of the risk factors that's usually associated with many of health conditions. So this is a blood glucose monitor. So diabetes is a risk factor. That's a blood pressure cuff. Hypertension, long chronic uncontrolled hypertension is a risk factor. And this one represents it's a gene, so it represents a family history of stroke. And also, I wanted to go into race as well. So minorities are at higher risk of stroke. Minorities including African Americans, Hispanics. So that patient population has higher rates of hypertension, diabetes, obesity, all those being risk factors for strokes. Okay, so moving on into the treatment. So as I alluded to before, I'm going to focus more on ischemic and TIA, or transient ischemic attack. Okay, so here the box here outlined in red, those are the ones I'm going to focus more on. This area right here, this is a little bit more of a gray area. It's not black or white. So this is more just for FYI. But this is just a basic steps of what's done when a patient is experiencing a stroke. So first of all, the or providers, neurologists are going to assess whether the patient has a disabling deficit present. So what I mean by disabling deficit present, that means that they have those symptoms that I mentioned before. So the loss of coordination, balance, visual loss, slurred speech, inability to communicate or understand speech or express. That's what aphasia is. So what's done next is a CT scan or MRI to see if there's any abnormalities going on in the brain, if there's a clot, if there's bleeding. So alteplase, I'll get a little bit more into that of what it is on the next slide, but alteplase is a medication that's essentially it's a clot buster. So if there's any clots present, it dissolves those clots that can be found in the blood vessels in the brain. So if they're eligible for alteplase, and on the next slide, I go into what makes a patient eligible for alteplase, then they'll receive alteplase. If they are eligible for alteplase, they'll receive alteplase. However, if they're not, then what will be assessed next is whether there's a large vessel occlusion present. What I mean by that is if one of the major vessels that supplies blood to the brain is occluded or it's blocked. So if it is blocked, then they'll receive what is called endovascular therapy. Endovascular therapy is when a catheter is inserted through the arm or through the groin area, and it's moved towards the clot guided by x-rays. And at the end of that catheter, there's sort of this mesh network, which sort of works like a net. So what it does is that it captures that clot and it removes it. So if patients are not eligible for alteplase and they have no large vessel occlusion present, then they'll receive a single antiplatelet therapy. Single antiplatelet therapy meaning aspirin. So that's what's done if the patient has those disabling deficits, as I mentioned to before. So if there's no disabling deficits present, then what is done is that this ABCD2 scale, it's a scale that it's basically just looking at the age and the age of the patient, whether they have diabetes, and other numerous criteria. If they're given a point scale, so if that point scale is greater than or equal to 4, or if in the MRI or in the CT, there is an acute infarct found. An acute infarct is essentially just a localized area of dead tissue. So if those two criteria are met, then they are considered high risk. So if they're considered high risk, then they will actually get 2 antiplatelet therapies, the most common being aspirin, and the other one, what we call a P2Y12 inhibitor, clopidogrel. They'll receive those 2 for the first 21 days. At 21 days, they'll drop either one of those 2 medications and they'll just continue one. And the reason for this is there's a trial. I can't recall the name of the trial, but there's a trial that assessed the benefit of taking 2 antiplatelet medications in the first 3 weeks. And there was benefit found in those first 3 weeks in terms of preventing a stroke. And there was also a decreased risk of bleeding, since both those two medications are what we consider blood thinners. So essentially, a patient is at higher risk of bleeding. However, in that trial, those two medications were just taken for the 3 weeks or 21 days. The risk of bleeding was very low. And in a separate trial, they actually assessed whether dual antiplatelet therapy was beneficial actually in a 90-day time span. And what they found is that taking 2 antiplatelet medications in a 90-day time span, there was a higher risk of bleeding with no benefit. So that's why the guidelines recommend just 21 days of 2 antiplatelet medications compared to taking 2 antiplatelet medications more than those 3 weeks. All right, so if patients don't meet these 2 criteria, then they'll just take just one antiplatelet therapy. So they're considered low risk, so they'll just take one. Hopefully that makes sense and I explained it well. All right, so these are the factors to consider for alteplase therapy. So what makes a patient not eligible to take alteplase? So if they have any sort of history of bleeding, so if they've have a history of bleeding in the brain, if they've had a previous stroke within the last 3 months, if they have had head trauma which resulted in bleeding, if they have mild non-disabling stroke. So mild non-disabling, as I mentioned before, when we went through the guidelines, they are not eligible for alteplase. If there's extensive hypoattenuation, so what this means is that there's extensive or severe brain damage that's irreversible. So they are not eligible to take alteplase. All right, so moving on into post-stroke. So post-stroke, so all patients after stroke get rehabilitation of some sort. So 10% of stroke survivors recover completely. 10% require a long-term care facility. 25% recover with minor disabilities. And 40% have moderate to severe disabilities. And this is what's concerning right here, because that's almost half the patients have some sort of disability post-stroke. So with rehabilitation, so just depending on what areas of the brain are affected, determines what type of rehabilitation services they'll receive. So an interprofessional team of professionals will plan and develop a rehab program according to the area of the brain affected. So occupational therapists, neuropsychologists, a speech language pathologist, dietitians, social workers. And this is not an all-inclusive list. I just included some of the ones that are most common. So prevention. So as with all medical conditions, exercise is usually like the #1 thing or physical activity, to be exact, is the #1 thing for prevention. Eating a healthy diet. So making sure we have those vegetables, those fruits, those limiting unhealthy fats, as I believe Harrison alluded to. So those saturated fats, those trans fats, and eating more of the healthy fats, such as your almonds, your avocados, your seafood, your fish, your omega. Eating more grains, eating more whole wheat, eating. It's okay to eat less. It's okay to eat lean meat, but just to a moderate portion. And also smoking. smoking is also associated with many health conditions, and there's a lot of data linking it to linking it and linking it to various health conditions. Okay, so these are some of the key takeaways that I think is most important to for all of us. So stroke is caused by blockage or rupture of the blood vessel, resulting in a reduced supply of blood to the brain. The three main types of strokes, excuse me, there's this ischemic, TIA or transient ischemic attack, hemorrhagic, risk factors, including diet, smoking, diabetes, high blood pressure, physical inactivity. The treatment depends on the type of stroke, and rehab is planned based on deficits the patient presents with. Okay, and for wrapping up, this is just more of a FYI. So there is a study called the FLAME study, which essentially assessed the impact that fluoxetine or Prozac, which is a selective serotonin reuptake inhibitors or SSRI, it assessed whether it improved motor skills post-rehab in patients in the first 3 months. So there is some data suggesting that it did improve the motor skills post-rehab and within the 3 months time span. So just so you can be, just so you can be familiar and aware that some patients post-stroke might be taking fluoxetine for that indication. However, some limitations of that trial is that it didn't really assess what were the long-term effects. So there is still sort of a black and white gray area whether the benefits are still seen more in a long-term interval compared to just the 3 months that was assessed in that trial. But that's more just of your for your information. Okay, so these are the resources that I used to compose this presentation. And hopefully you got something out of the medication, not the medication, but hopefully you got something out of the presentation. And just to wrap it up, the most important thing to me is probably just recalling and remembering the BFAST acronym, because being familiar with that can save people's lives if they get treatment in a timely manner. So the floor is now open for any questions you might have.
Excellent. Cesar, for those of you who are still on the call, I wanted to let you know that Cesar actually found the BFAST acronym. He actually found it because we used it for somebody else earlier this month in Spanish. So if you want that for your Spanish speaking patients, just let me know and I can forward it off to you as well. And I'm currently looking, Cesar, I'm not sure if I see if anybody has had any questions, but overall, very good job, very thorough, very complete.
Thank you.
And I'm trying to give it to see if I see any people unmuting themselves, and I do not. So I'm going to go ahead and say, I have a comment and it says all three presentations were great and quite thorough, and the person says to say thank you all. So thank you. So as far as I can tell, I think we are done. Thank you, learners, so much. Learners, I will see you tomorrow. You should have the address for tomorrow.